Hello, my name is Meyer, and on behalf of our study team, we would like to thank the Scientific Program Committee for allowing us to present our study entitled Urinary Incontinence and Hip Strength in Older Women. These are our relevant disclosures. Urinary incontinence is considered a multifactorial and highly prevalent aging-related condition leading to significant morbidity and disability. Notably, incontinence disproportionately affects older women and affects up to 50% of community living older women. Interestingly, urinary incontinence has been shown to be independently associated with increased risk of falls. And there is significant overlapping of risk factors between urinary incontinence and falls, such as aging-related decline in physical function and skeletal muscle strength, including osteoporosis. Therefore, the primary aim of our study was to compare bone mass, bone quality, and muscle strength, both hip and pelvic floor muscles, in postmenopausal women with and without urinary incontinence. We hypothesized that women with urinary incontinence have lower skeletal muscle strength compared to those without urinary incontinence. This was a cross-sectional study including women 55 years or older undergoing universal osteoporosis screening from 2018 to 2020. The presence of urinary incontinence was defined as having one of the following. 1, at least moderate UI, which is scores 3 or higher on a validated incontinence severity index. 2, positive cough stress test. Or 3, history of incontinence treatment. Bone assessment was performed using DEXA scan. Bone mass was measured by bone mineral density and bone quality by trabecular bone score. Maximum hip muscle strength was assessed using a handheld dynamometer, and pelvic floor muscle strength was measured by a peroneometer. Muscle strength was compared between groups, and the mean outcomes of 3 trials were analyzed using generalized linear models adjusting for covariates potentially influencing the difference observed between groups. Statistical significance was indicated at a 0.05 level. Of 41 women, 18 women had a urinary incontinence and 23 women had no incontinence. No difference in clinical demographic characteristics were noted, including age, race, BMI, as well as comorbidities, estrogen use, vaginal delivery, or smoking status between urinary incontinence and no urinary incontinence groups. There was no difference in bone assessment between women with and without urinary incontinence. In addition, no difference was noted in pelvic floor muscle strength between women with and without urinary incontinence. However, women with the urinary incontinence had significantly lower hip strength in flexion, abduction, adduction, internal and external rotation compared to those with no urinary incontinence, controlling for age, race, bone mass, and quality. While no difference was noted in pelvic floor muscle strength between groups, women with urinary incontinence had significantly lower hip strength compared to those without urinary incontinence. The continence mechanism relies on intact pelvic floor support, and surrounding anatomic structures beyond the pelvic floor could play an important role in maintaining pelvic floor strength and function responsible for continence through muscle coactivation. Therefore, targeting to increase hip strength with pelvic floor muscle strength may improve pelvic floor function and incontinence symptoms. A combined hip and pelvic floor intervention may be warranted in older women with incontinence. Thank you.